Okay. Good morning, everyone. On behalf of ISA Chidambaram and Department of Anaesthesia and Pain Medicine, I am delighted to welcome you all to this pre-CME online academic activity focusing on simulation. As we all know, anesthesia is a highly critical field that requires precision, decision-making, and teamwork. Simulation plays a critical role in helping anesthetists to handle challenging and high-risk situations before they face them in real life. Learning in a safe and controlled environment, we can develop confidence and skills to handle any difficult conditions. Beyond technical expertise, crisis resource management is essential in anesthesia, especially in obstetric field, where safety of both mother and fetus depends on timely response. Now, even anesthetists and surgeon also. We look forward to an engaging and insightful session. Before that, I would like to welcome all the eminent faculties from all over the nation. We are honored to have senior consultants from across the nation, along with our esteemed and eminent speakers, Professor Dr. Ashoka Balakrishna from National University Hospital, Singapore, and Dr. Tilaka, Clinical Lead Simulation Center from Apollo, Chennai. We also extend our warm welcome to our esteemed and respected chairpersons, Professor Dr. Lenin, HOD, JIPMA, and Professor Dr. Amudarani, Dean, Government Medical College, Ramanathapuram Medical College, and Chief Election Officer of ISA Tamil Nadu. And I also welcome the postgraduates who have joined us today. Despite her busy administrative schedule, Madam has kindly accepted our invitation to chair the session. With 22 years of teaching experience and expertise in teaching and obstetric and pediatric and transplant anesthesia, she has made a significant contribution to the field. She has received many awards from both national and state awards. She has organized many workshops and conferences. She has many publications to her academic credits. I am also honored to welcome Professor Dr. Lenin, who is a highly accomplished anesthetist and finished his MD from AIIMS, Delhi. He currently serves as a professor and HOD at JIPMA. He is a faculty in many national and international conferences. He is a past president of ISA Pondicherry with 25 index publications. He brings immense knowledge and insights to the session. And I welcome and I'm thankful to the Dr. Balavengat sir. He's a national president. He had made his valuable time and he is somehow he arranged his schedule to fit in us. It is a great pleasure to welcome our eminent speaker, Professor Dr. Ashoka. I have had the privilege of knowing him for the past 2 decades. He has been a pillar of expertise and dedication and inspiration in the field of anesthesia. As a passionate teacher and researcher, he brings a wealth of knowledge and experience, making learning both engaging and insightful. We truly appreciate his time and looking forward to learn from him. It's an immense pleasure to welcome our esteemed speaker, Dr. Tilaka, a person whose knowledge is matched only by her infectious enthusiasm and energy. Thank you, ma'am. Thank you all for joining us. I request Professor Dr. Amudarani Madam to chair the session. Before that, I request Dr. Balavengat to share a few words with us.
Thank you so much, Subbulakshmi Madam, for organizing this. I think it's very, very crucial and important as the Indian Society of Anesthesiologists, all the leadership should focus on enhancing the knowledge, skill sets, and the attitude for every single anesthesiologist in this country. And I think this act of the Chidambaram branch of ISA is extremely welcome because you have chosen a topic which is of great relevance and which would directly influence the morbidity and perioperative mortality. And simulation-based learning has become one of the most important component of learning throughout the world. And thanks for making this happen. And I'm extremely delighted that you have with you a lot of luminaries from the state leadership, from the national leadership, and we have 2 eminent chairpersons, Dr. Lenin and Dr. Amudarani, and 2 excellent speakers, Dr. Tilaka and Dr. Ashoka. Dr. Ashoka, I've seen him do this in several forums across the world, including the World Congress of Regional Anesthesia in Paris, where this workshop on obstetric-based simulation was a big success. And I'm delighted that Chidambaram branch will continue to do this knowledge exchange, and I wish all the very best for this event. Today, I'm in Ahmednagar in Maharashtra to deliver a oration and install the new team of office bearers. But I took 10 minutes permission from them, and I postponed the session from 9 o'clock to 9:10 to make sure that I'm part of an excellent event organized by ISH Chidambaram. On behalf of the entire Governing Council of Indian Society of Anesthesiologists and Dr. Hina, the Governing Council member from ISA, I take this opportunity to thank the leadership of Chidambaram and Tamil Nadu State in organizing this. Thank you so much and have a great session. Over to Subulakshmi Madam.
Thank you, sir. Thank you very much for your valuable time. We are very much delighted and honored by your thing, sir. Thank you, sir. Thank you very much.
Thank you, Madam.
Now I request Professor Dr. Amudarani Madam to chair the session.
Respected National ISA President Bala Venkat sir, Governing Council Executive Member Hina Madam, other past and present ISA office bearers, esteemed faculties of today's program, other professors, assistant professors, and my dear students. Very good morning to one and all. It's an immense pleasure to be part of today's event as a chairperson. Kudos to the Professor Subulakshmi Madam and the entire CISA team for such an innovative new idea of conducting pre-conference CME academic session. Congratulations and best wishes Chidambaram team for CISA to be successful. The first topic for today is crisis resource management and principles, which is going to be delivered by our faculty, Dr. Tilaga Mutaya, who is a clinical lead of simulation, consultant anesthesiologist, Apollo Simulation Center, Chennai. And she was a assistant professor from 2016 to 2021 in AIMS Delhi and Chettinad Hospital. Her areas of interest are simulation-based technique, quality improvement, airway management and critical care, post-operative outcome-based clinical research. Her achievements are, she is a national editor, Chettinad Healthcare Medical Journal, reviewer, Indian Journal of Anaesthesia, founding member of Neonatal Anesthesia and Society, faculty in national and international conferences. She is a member of AHA, BLS, ACLS course, and she is an instructor also. Crisis resource management is essential for any organization or an individual of any capacity, especially for a profession like an anesthesiologist, pre-operative physician, and critical care physician, as all you know. A well-prepared and well-prepared mind or a person or a trained team can mitigate a damage, navigate crisis most effectively, and emerge stronger. Regularly updating crisis management plans, training employees, and engaging in scenario like this and simulation like this can enhance individuals' resilience against potential crisis. Let us have an academic feast by Tilaga, followed by Ashoka Balakrishnan. All the best, and let us start the program. Tilaga, over to you.
Thank you so much, ma'am. Good morning, everybody. I'm so humbled to be in the presence of such amazing people. Thank you so much, Amuda ma'am, for a lovely introduction. And thank you, Subulakshmi ma'am, the entire ISA, Bala sir, and all the office bearers, ISA Chidambaram, for this wonderful opportunity. I'm going to share my screen now. Yes. Is my screen visible?
Yeah, visible, yeah.
Thank you so much, ma'am. So today we'll be discussing about crisis resource management, and I bring warm greetings from Apollo Simulation Center. There are such seasoned teachers in the group, so this might be a repetition for them. A lot of it will be already practiced by them, but I have tailor-made the presentation to suit the needs of the postgraduates. So I will be very happy to take inputs from all the amazing academicians and clinicians present here by the end of the talk. Because it's a Sunday morning and we will all be looking forward to something that is interesting for us, I'm going to make it as simple and interactive as possible. And for everybody, I want them to first picture themselves, close their eyes and picture themselves in an operation theater where we are the anesthetist for a surgeon with reputation to be getting jittery, to be throwing things, to be stressed out even when the slightest of problems happen. I'm sure it will not be difficult to picture at all because each and every one of us will have had at least one episode where we have been associated with such a surgeon. But I just want to picture yourself that in this particular case, there is a laparotomy happening. There is a massive bleeding, and now the surgeon's extraordinarily anxious. He started screaming at the assistant first, and then the OT technician that the light is not okay, and then the sisters that the equipment is not okay, and started throwing the equipment, and then the anesthetist that the plane of anesthesia is not okay. And you're the anesthetist there, and you're dealing with a massive bleeding in the midst of so much of stress. And because it was not anticipated, you didn't secure a central line, you're trying to secure a central line, you have a new resident with you, and you're just turning around in the middle of putting the guide wire and saying, okay, I want you to start NORAD at 5 ml. And something about the look of the resident tells you it's not okay, but then you have to finish the procedure, and you're trying to finish the procedure and you're looking, and he's holding a 5 ml syringe trying to inject, and you stop him. Now, he loaded a 5 ml of undiluted noradrenaline and was going to push to the patient, but you prevented that from happening. But if it had happened, obviously the patient would have gone into an arrest and we would not have been able to salvage the patient. Now, I want you to tell me who is responsible or what just happened. How did this, and who is responsible for this event if it had happened? So I'm going to give a minute for each and every one of you to type your answers, and I'm going to request Lenin sir to tell me if there are some answers in the chat box, because I won't be able to see the chat box. I want you to think and tell me who is responsible for this event. Just type whatever you want in the chat box. It might or might not be right. Yes, I can see the chat box. As anesthetists, no feedback, acknowledgement, both the person who loaded the drug, excellent. Please keep the answers coming. The person who loaded the drug. Okay. So now let's see that no event occurs with one person being at fault. For want of time, I'm trying to move forward. So the bleeding is something that we really cannot prevent. Like that's an event. If it had to happen, it will happen. But the panic created by the surgeon is something that could have been addressed. Because of the panic, a lot of things gets one after the other deteriorated. And when we give orders as somebody is not muting. I'm going to request everybody to go on mute. Thank you. So, and when we give orders, as long as we are giving clear orders and we know that those orders are understood well, then it's okay. But if we are doubtful, then we have to give clear orders. And the resident, when in doubt, we'll also have to think about the resident. There is a surgery, there so much of screaming is happening, so much of anxiety, so much of blood loss. They would not have seen all of these things. So when in doubt, it's very difficult for them to speak out. And unless we keep instilling that thing that they need to speak out when they are in doubt, it's going to be difficult for them to speak up. So all of these together will work to cause patient harm. Anywhere any one thing is prevented also, patients will not be harmed. So in the next, say, 15 minutes, what we're going to discuss is what is this crisis resource management? Because technically, all of us are sound, all of us are well-intended. But when crisis happens, there is a different situation. And these non-technical skills will ultimately determine the outcome of the patient and how can we function efficiently as a team. So when we say something as crisis, what do we mean by crisis? Crisis is a situation where outcomes can be bad. And usually, whenever there is a crisis, it's going to be difficult to deal with because they are not normal things. And usually the progress is so rapid that at 1 minute, there is something, at 5 minutes, there is something, at 10 minutes. So it's an evolving thing. Automatically, whenever a crisis happens, everybody, however experienced we are and whatever well-read and technically sound we are, there is an amount of fear, anxiety, mental block, and fixation. We can reduce it, but this not being there is a very idealistic situation. I don't know how many people will be able to achieve that. If we can achieve that, it is amazing. But it is normal and human to have all of these emotions going through. And during these emotions, how do we tackle that situation is crisis resource management, which is the ability to translate whatever knowledge we have, the algorithm we have in mind, the techniques we have into real world actions, because emergency is a different situation and elective is a different situation. So these skills, which broadly will be called as non-technical skills, will be the skills that are required for managing crisis efficiently. There are a lot of crisis resource management principles, and we will be looking at each one of them and how they will be important to affect patient outcomes. Like I already mentioned, there's nothing that is very technical about this talk, but every one of you reflect on how many times have you seen people around you follow these principles and how many times each and every one of you follow these principles. So it's a very reflective thing that would be amazing by in the course of the talk. I'm going to give another small exercise. And there might be a few people who already know the answers to this, but it's nevertheless okay to tell the answer. And the job is to attach the candle to the wall without wax dripping on the table. You have a candle, you have matchsticks, and you have a box of board pins. So I'm going to give about a minute for each and every one of you to think. And again, I'm going to look at the chat box to see, oh, no, I gave off the answer. But anyways, if you haven't seen the answer, I'm going to request you to think about how can you attach this candle without the wax dripping on the table. You could unmute and tell, or you could type it in the chat box. Again, I'm going to request Lennon sir and ma'am to tell me if something is coming up in the chat box. Think about what you have. Think about strategies. Think about how can we do this? Because most of the times, anesthesia is about identifying, is about strategizing. Do any of you have the answers? You can actually unmute and tell.
First answer has come as attach and don't ignite it.
I think that's an amazing way of doing it. If you don't ignite at all, no wax will drip. No, they never thought of that. Amazing. It's all lateral thinking coming up. Excellent.
Yeah.
Okay. This exercise usually takes some time. But for want of time, I'm going to move forward. So the box is a separate property. The board pins are a separate property. Usually this exercise is done for lateral thinking. And if we say a box of board pins, then it's very difficult for people to think of the box as a separate property. But if we keep the box separately and the pins separately, then most of them come to this solution in less than 5 minutes. We never gave you 5 minutes time. So if we give you time, you will eventually be able to come to this solution. Now, why am I saying this? As anesthesiologists, it's extraordinarily important to know what is there in our environment. And by environment, I'm not talking only about physical things around. By environment, I'm talking about, say, for instance, the location of a defibrillator. Okay. If we don't know where a defibrillator is, it's going to be very difficult to summon somebody to get it. Okay, fine. Then how to use that particular equipment? If we are not aware of how to use the defibrillator because they have ended up buying a new brand of defibrillator, it's going to be very difficult. So knowing the environment means knowing exactly, eyes closed, when we enter the OT complex, we should be able to tell where is the backup oxygen cylinder kept for the entire OT. Where is a defibrillator kept? Inside my theater, which shelf do I have to reach out if I have to take this particular drug? Do I know how to open the card? Okay, today, who is the resident who's going to be posted with me? I'm not at all asking to judge the resident, but is it going to be a junior person? Is it going to be a senior person? What is the kind of case that I'm going to deal with? And suppose I need to escalate and call for help, how quickly can help arrive? And who is the person I'm going to call? All of these things, knowing all of the local protocols that involve operations, all of these things are about knowing the environment. And eyes closed, as an anesthesiologist, we should be able to tell what is kept where and how to reach out and how to operate each and everything in a simple way to somebody else in a very, very relatable way. So that is about knowing the environment. I'm going to ask for another question and picture yourself. Now, I want all of you to think that you're a resident and you are on night shift. And when you're crossing the labor room just like that in the night, and you're just peeping in, there's a patient screaming, and the patient is about 120 kgs, having contractions. They're waiting for the consultant obstetrician to come and take a call. But on inquiry, the patient is having preeclampsia. The blood pressure is somewhere around 160, 170 systolic, and the diastolic is 100. Once the obstetrician comes, there is a huge possibility that this patient might be wheeled inside for cesarean. So now, what all things will run through your head? You can type in the chat box. What will run through your head and what will be your thoughts at that time? So think about from a resident's perspective. Okay, this case is going to come. We are going to airway, full stomach, emergency drugs, preparation to start for cesarean. Absolutely amazing. NPO status, coagulation profile, blood reservation. Absolutely. All of these are drugs, especially Maxelf. Amazing. So all of these are very important. How many people will think for calling for help immediately? Because you know that this person is going to land up in the OT table in the next 10 minutes. Who am I going to alert? How am I going to alert? And how am I going to call for help early? Because help will arrive in some time in the middle of night. It's not going to be easy for people to wake up, get ready, come rushing. So all of what you have said is absolutely important. Now, why I'm saying so much emphasis on calling for help early is simply because when call for help arrives, you have cognitive help. Somebody is going to help you in decision making. Physically, if you're struggling to place whatever, an airway if you choose to give GA, or a regional if you choose to give regional, depending on the pros and cons of that particular case, physically you have somebody else to help you. And by summoning help early, you have already taken organizational help, because when something goes wrong, people will not pin you because you followed the right protocols. And when I was a resident, sadly, I used to think the airway is only a little bit difficult. No, why are these people making so much fuss? Why so many people are standing around? We have one fiber optic, we have one video laryngoscope, we have everything. And then normal laryngoscopy we will do. I'm like, why are these people making such a big issue of this airway? But that is simply because I was so inexperienced and I had no idea of what can go wrong. Because what is the other thing that can happen? We've not arranged for all of these things and we end up in a CVCAVI. Suppose in a whatever difficulty intubation or a difficulty in ventilation or difficulty in both, then what happens? Then who comes to help us at that time? And how will we justify ourselves to our own conscience as well as to legal people as to what we did was right or wrong? So the simple rule of thumb is when you think that you have to think a lot, and when you think, should I call somebody for help? That means these are indications that you have to call somebody for help. So that is the simple rule of thumb. And the next very important non-technical skill is the ability to take leadership. Now, who is a leader? I've put some drawing where the leader is also trying to pull. I want yes or no now on what do you think? Should leaders be actively involved in doing things while the other people also doing things, or should a leader not do things? Just yes or no. Should a leader be involved in task management? No. Superb. No. Superb. No. Okay, significant number of no's. Amazing. Leader has to command only. Excellent. So by this picture, we're telling that the leader is not a person who just throws instructions, but becomes and behaves like part of a team. But technically, when you have enough people to manage things, of course, when you don't have people, you will have to do multiple things. But if you have people, the leader has to step out, be at the foot. Of course, in an emergency resuscitation, foot end is better, but as an anesthesiologist, always head end is better. You need to stand away and be able to see what is happening and take decisions accordingly, help people do things, involve all team members, summarize treatment plans. And that is the role of a leader. The leader is not the person with maximum knowledge, maximum skills. Leader is a person who has the ability to think and is willing to take responsibility for their decisions and to guide people and be able to tell that I have no idea, do any of you have anything to talk to me about? So that is leadership. Vulnerability is leadership. Commanding is not at all leadership. Leadership is being able to inspire team members to do better. So who becomes a good leader is always a person who can become a good team member when they are not in the leadership position. So in a day itself, in one case, somebody could be a team leader, and the next case, somebody else could be a team leader. So this is a very dynamic proposition. And the ability to work well in a team, the ability to become a good team member is very, very important. And when you become a team member, having role clarity is the commonest thing that can actually affect patient outcomes in a very brilliant way. And if you are not sure about something, say for instance, I'm not comfortable securing a central line, but I'm a little bit more comfortable in taking care of the airway. And if the leader says, please kindly go and place the central line, it's a good idea to say, I am not so comfortable in doing it. Can I take the airway and can somebody else take the role? Instead of trying to do that, getting into trouble, creating a hematoma, and then making it difficult for the team leader to go and work, it's all right to say, I am not comfortable. It's okay to say, but don't keep saying no to every single thing. By what am I meaning by it's okay to say? It's okay to say no, I'm not comfortable. And it's really important to go back and work on why you're not comfortable with that particular skill or with that particular task, and take training, take help, and make sure that the next time such a task is being assigned to you, you are ready and prepared to take up the task. But at any point in time, if you feel that you're not geared up, it's a good idea to say, no, I'm not comfortable, I need help. And immediately, it's also a responsibility to go back and work on it and make sure that the next time you don't have to say that. And one of the most important things that all of us keep talking about is effective communication. That is like the cornerstone of good patient care practices, patient safety, quality, everything. Because in a crisis, there will always be chaos. There will always be confusion. There will be so much noise. Everybody is talking. Unless we speak out clearly, unless we are loud, calm and clear, people will not be able to carry on information from one end to the other. We are screaming, half the information gets passed. So all of these confusions will happen. So it's very important to be loud, calm, clear. Can you hear me now?
Yes, madam.
Yes, we can
Now
hear
we
you.
are able to hear you.
It's very important that we kind of pass on messages well. And how do we do that? A very important technique called closed loop communication. I'm sure all of you would have heard about it, but it looks so basic, right? It looks so simple. And this is something that cannot happen only in crisis. This has to happen every day. Only then it will come forth in crisis. So closed loop communication is something that we need to follow every single day for every single instruction that we either give or receive. So when we give an instruction, it's important to say, for instance, if I'm going to request somebody to give, please give 1 milligram adrenaline followed by a 20 ml bolus. I have to wait for the other person to say, okay, I will give adrenaline 1 milligram followed by a 20 ml bolus. And then once they give the drug, it's expected that the person who has given the drug will tell us that I have given the adrenaline and the bolus, and for us to acknowledge, thank you, which means the instruction that I have given is a complete, clear instruction. It has been understood by the person. It has been executed by the person. And I have been informed that that particular command has been executed. So that closing the loop is extraordinarily important, and it doesn't come in one day. It has to be practiced every single day. Another very interesting thing is fixation. Now, what is fixation? Fixation means we are kind of fixated to a particular thing and we can't think beyond it. Like in one of its form, we're saying, okay, fine, we're having tachycardia and hypotension in the theater. There is 500 ml of bleeding. And I'm like, this is because of bleeding only, not thinking about anything else. Cognitive tunnel vision. That is error one. Another variety is we are thinking about everything. Oh, this is tachycardia and hypotension. This could be MI. This could be sepsis. This could be bleeding. This could be pulmonary embolism. We have to make clinical judgments based on what is past history, what is presently happening, and narrow down to diagnosis. So it's not just important to have differentials, but it's important to narrow down. And the third is one amazing thing, which is like, there's tachycardia, there's hypotension. Why everything sounds and seems okay? Why is the BP low? The BP cuff is not working. Change the BP cuff. And then they're bringing one more. All BP cuffs in the OT is not working. Everything is okay. So if we are not going to trust the equipment, if we are not going to trust the reading, then why use that equipment? So we need to use clinical judgments. And whenever fixation happens, which is very common and can happen for anybody, there is a good way to follow this 10 for 10 concept, where we stop 10 seconds for every 10 minutes. Every 10 minutes, we stop for 10 seconds. Step out, because we might be going in circles and not being able to diagnose a problem. Okay, fine. I'm going to stop for 10 seconds. What's the problem? Who are my team? What are the facts? Let's plan, distribute, and other questions, which means somebody will come up with something where that fixation will get corrected and then we could act. I know I'm exceeding time. I'm just going to take 2 more minutes time. I'm not going to do this picture yourself, but I'm going to say directly about the very important other concept of having a shared mental model. So I'm just going to give this example of a recovery room where we are having a post-thyroid surgery patient, and the patient has developed some kind of a breathing difficulty. We are thinking about a lot of things, and in our mind, we know that, okay, fine, this patient might be having bleeding. That's a hematoma that is causing airway compression. But we'll be like, somebody get the oxygen. Okay, nurse, call the surgeon, you get the kit. So nobody will understand anything. They will keep following orders, but they'll have no idea. But if we stop and say, hey, listen, This is a post-thyroidectomy patient. I think we're going for an airway compromise because of bleeding. I'm going to secure the airway first because I know that best. In the meantime, nurse 1, I want you to get equipment to remove the suture. My resident, I want you to call the surgeon and get the theater ready. We do not have time. We need to act quickly. So once you open up and share whatever is in your mind, then everybody falls in line, and thinking out loud and continuously reviewing what is in our mind will help the team members being aligned, and they will be able to give us inputs, and they will be able to function better once they know what they're dealing with. So that is about shared mental model. And with that, I'm going to stop sharing and thank all of you for the amazing and wonderful opportunity. And the whole point is not about doing this in emergencies at all. It's about doing it every single day, reflecting on our behavior every single day, ensuring that every single team member is able to understand that we are all working towards patient care. And simulation is one of the most amazing ways of taking care of non-technical skills. So whenever you have a simulation class planned by your teachers, which is very difficult, please go and participate in that simulation class and be vulnerable. Volunteer to be part of that simulation class. And if each and every one of you can think that it is important and do it, then I think this attempt is a very fruitful attempt. So thank you so much. Thank you, everybody.
Thank you very much, Dr. Tilaka. It was very interesting and then very nice lecture.
Thank you, sir.
You have told all the concepts. I hope we'll get more questions from the audience. You can type in the chat box.
Hello.
Amuda ma'am,
Thank you, Tilaka, for your excellent presentation.
Thank you, ma'am.
Is there any questions from audience? Or shall we have the questions in the end of the session?
We can have questions at the end of session, madam.
Okay.
Okay.
Ma'am, can I ask
Over to Lenin, please.
To Tilaka, please. Yeah, you rightly pointed about the leadership thing. Hello?
Lenin, sir?
Yes. No, you rightly pointed out somebody is asking a question that the reverse Volant model to pull back the effect. Can you just take that question?
I'm not aware of what the reverse Volant model is. If if they know it, or if somebody else can talk about it, I would be very happy to hear about it.
Maybe the speaker, Dr. Praveen Kumar can unmute himself and then ask the question. Maybe that will give more clarity so that you can take up the question. Dr. Praveen, can you please unmute yourself and ask the question? Is it okay?
Dr. Keshav, you unmute Dr. Praveen.
Yes, please.
Sir, is I audible, sir?
Yeah, Dr. Praveen, it will be nice to see you also. Maybe you can put the video also, if that is all right.
Yes, sir.
Hey, Dr. Tilaka.
Sir, do you visible, sir?
No, sir. No, sir. You can just.
You can keep asking questions. You can extend the question, and then we'll see.
Reverse Volant model is just to know the cause and effect, sir. Something has triggered and something has been started. Event has been started. So one cause leads to one effect, and that effect becomes the cause for the second effect. So the patient will keep on moving away from the goal which we are planned. So we need to go one step ahead and prevent that effect, so that that effect will not become the cause for the next effect. Like if the heart rate is increasing, the BP will come down. So if you stop the if you decrease the heart rate by giving a beta blocker, then the BP will increase up. So the reverse model is they will divide the patient safety zone into 3 zones like green, yellow, red. The patient is moving away from one zone. We should try to pull back the patient to the green zone. So this is the model they would have given.
Superb, sir. Thank you so much. This is a new concept for me. I will
just I can show the diagram if everybody is interested.
Can I ask one question to Dr. Tilaka? Because we are telling about the leadership thing. Most often what we face is when there is a hierarchy level is there, like junior resident is there, then SR, then faculty member. How do you like overcome that fear, that hierarchical thing is there? So they'll be scared or, they don't want to talk in front of the consultant. So how do you do that? Help them?
So I'm also very intrigued about this. So when I was thinking about the army. Army is a very hierarchical system. They respect, they will always listen. Yes. But an army during war will always have each other's back. Everybody will step up to the next role and everybody will be saving everybody. Everybody will listen to everybody. There will be hierarchy. There will always be hierarchy because only then there can be order. But during crisis, during war zone, there will be no hierarchy. Everybody will have everybody's back. So for us, I wouldn't say that we have to always have a flat hierarchy. That wouldn't work. There has to be some control. People will have to listen to everybody. So that hierarchy is important during peace. That is outside of OT. There is peace. Inside any OT, even in an elective surgery, I feel it is war zone only because anytime the conditions can change. So OT is like war zone. And so in war zone, everybody is working together towards one goal. Like for the country, Indian Army is working. We're working towards that patient. And to save that patient, anybody's input is welcome. Anybody's good intentions are welcome. But there is one team leader who takes up that leadership role and ensures that everybody does it, sir.
Okay, good, I think. Maybe with the repeated training, they'll be able to get that thing.
Yes, sir.
Okay, and there's another question. Can you see the chat box or should I read for you?
Which one, sir?
Dr. Sankita mentioned that I have a question for you in a hierarchical society with a concern of repercussion. How do we...
Sir, it has been already answered, sir. Thank you, thank you.
Okay, fine.
Thank you, ma'am.
Okay. Shall we move on to the next speaker, ma'am?
Yes, sir.
Okay, thank you very much, Dr. Tilaka.
Thank you, sir.
Okay, now I'll have the privilege to invite Dr. Ashoka Balakrishnan.
Correct.
He's a senior consultant and anesthesiologist from National University Hospital from Singapore. And he is, since very long, he's working in the simulation. He's organized several simulation workshops and he's a research lead in the AME program. And he's currently the vice president of the Pan-Asian Society of Simulation. And he has a lot of interest, especially with respect to the simulation-based teaching in obstetrics and regional anesthesia. And he is more towards the postgraduate exam support with respect to the simulation-based training. And a lot of obligations to the editor of 3 books. And I was fortunate to have 1 book from him. Thank you very much, Dr. Bala. And I think all of you are eagerly waiting to see you. And over to you, Dr. Bala, please.
Thank you, Dr. Lenin. Good morning, everyone. It's a lovely Sunday. Hope on all your houses, and you do not have to click your computers. Just listen to this, or you can have a recording later. I'm happy to be here, and thank you to Dr. Subbulakshmi. She was my senior resident, and I was the small boy at that time, and there used to be a lot of learning with her team of senior residents at JIPMA, and it's a privilege to have the present head, Dr. Lenin, with whom who pioneered the simulation department setting up. Last year we had been there. And for me, Chidambaram has a special meaning because the previous year, my team doctor was performing at the Chidambaram temple. So,
Dr. Hari Ramakrishnan, can you
thank you.
Hari? Can you please mute yourself?
So I hear the lovely home from every part of Sunday in all places. So let me stick to maybe 15 to 20 minutes, and that could help you all have some chats. Discussions are lovely. So if we are looking at simulation in obstetric anesthesia, it's very dear to me because my journey started with that. I will discuss about how I came into this. My backgrounds have been described. I think from India, where I had my training in anesthesia from JIPMA, I moved to Singapore. Presently, if you say Puducherry, they don't get it. I think it's Pondicherry, which was what it was known to be famous for. My present setting is National University Hospital. It's one of those red dots in the red dot, where the primary obstetric anesthesia is done in KK Hospital. NUH has a combination of all, and we also handle cardiac issues in pregnancy. So if we have to rewind to 22 years back as a 3 years as a resident, I guess a patient was a primary obstructed labor and she was in a lot of pain when we gave spinal. I was the first year holding the hand-on pulse, not the monitors at that time, hand-on pulse. I couldn't feel and I escalated. It was ignored and then it went on to the voice being husky and the patient collapsed. And what happened after was a lot of hypoxic damage with the patient going to the ICU and eventually demise. There were concepts of delayed recognition, poor acknowledgement, strong hierarchy, and the technology or the ways of escalation of errors were slow to start with. One important thing I would highlight is we did not have a standardized way of stopping when harm was happening, when hierarchy was coming in. So how do you curse, that is CUS, concern, uncomfortable, and patient safety issues are described. So we went on to do critical incident as my thesis, and we figured out that as Dr. Tikla was saying, before even the medication was given, you stopped it. So that happens about 70% of the time. How do we go about preventing that in obstetric anesthesia? We might have thought we figured this out, but you could see every 10 years something goes wrong. So here chlorhexidine is injected and the mummy Wang and the child Alex are now holding hands, but she can't move it because the saline looked like chlorhexidine and it was injected in a dim lit place. And here we have tranexamic has the message for all to be sorted, but I think bupivacaine and ampule, when it is swapped and given, 50% mortality happens and spinal thrombosis results. So that's in the recent 5 years which come out in a big way because the ampules are similar, which means every 10 years things change, but events are more ghastly. What do we do to prevent it? So how can we look at the aspects which Dr. Tila was talking about? We have to bite size it when it comes to advanced specialties like obstetric anesthesia. One could think of a skill-based event. So if you're driving a car, a cat comes, you don't tell your brain, hey, think about putting the brake, you just brake. And then rule-based. So you look at how we can form protocols and we stick to a way of doing, like following traffic lights and sticking to the lane. And the other one is knowledge-based errors of deliberation. So these require a thought process. You're lost in your map and you have to find your way through. You look at things which you know and you associate and figure this out. So these are the ways one moves from automaticity to conscious deliberation. So if you have to structure learning, we have to differentiate it on what needs your mind to work with and what should come unconsciously competent. In general, simulation, you tend to put them as part tasks where people are looking at how you deliberate practice to get a certain level of proficiency. And then you look drills. So that is algorithms. And then you can look at full scale simulation. And most of the times when even obstetric anesthesia or any simulation is said, so people buy mannequins and then say, hey, we have this expensive 4-level simulation building. Can you start now? So it has to be a curricular change. It has to be a fit to purpose or choose. So you don't sit on a bus and then say, will this go to Tirupati, right? So you just plan a travel, you choose what you want, and you have to design itinerary, which is your curriculum. In the same way, when we saw that 15 years of simulation, we don't see people getting the right outcomes. There was clinical iteration in our settings. Why is it that with all these expensive stuff, we still had problems? Because the mind was not trained and people were doing the same amount of things. So if you play a Mario game and you click, it has to jump and it'll become big and it'll throw fireballs. So it has to be an automatic way of how the mind works before the hands can think and the team can work together, which means we have to reconsider simulation in 3 different ways, where simulation for a milestone. You look at a competency or an entrustable professional activity development. And that is well sorted in the Indian context right now with the undergrad competency-based model, but in the postgraduates, much to be sought for. So Professor Ravi Shankar and his team did the EPA work, but we have to move beyond the individual being ready in the first instance, individual's mind being very much wired to handle a crisis, and in the level 3, you throw them into context where they could work with individuals in an interprofessional setting. So the journey comes from the novice being at the lower end to all the way becoming an expert. And you layer in either a clinical training below or a simulation based training above. And that is how somebody trains deliberately in a simulated context. There's faculty with focused feedback with increasing level of complexity, and they become expert in a simulated setting. And you bring them parallelly or sequentially into the clinical context, and then say, this person is ready, he can give an epidural, I'll be in the room, next time I'll be outside the room, next time I'll be having coffee, next time I'll be in Netflix in the house. So that's the range of how you develop. So if you look at labor epidural, I'm just picking one aspect of obstetric anesthesia, a simple technique to develop over time if you structure it, has to have the background of the things on the left: anatomy, physiology, pharmacology, equipment, skills which should be individual training and in complex settings, and then with crisis. So let's look at this image where we are doing a simulation training on a mannequin, where you could see that there's first a question about what antiseptic you use, the needle goes in, and then when the needle is halfway in, we say, stop, the patient is having a contraction. What do? You pass the needle, this time there is blood coming through. Then you do saline, loss of resistance, and you inject. The syringe bounces back. Then you inject the saline. A lot more saline comes, but it drips. How do you know it's not CSF? Then you do the spinal component. The needle goes in, and then you get CSF halfway through. It stops. This is labor epidural. Do you give or you don't give? This is DPE, and then the next version is after you remove the needle again, remove the spinal needle. The patient has a contraction. Then you say, hey, right now there is a difficulty with the patient having a contraction while your epidural needle is in. You're on catheter placed in. So at the time where you're placing a catheter, there is a difficulty in placing the catheter. So do you flush with saline? Do you push through with your catheter? Do you turn the needle south? Then you place the catheter, there is blood coming through the catheter. What do you do about this? Do you purge this? Do you do a technique in the next phase, etc.? It is a simple mannequin-based technique, but you need to have an organized way of making complexity with a simple skill. And that's how you can do it with how people can have their own mantra on how they load stuff. From the left to right is how I would. The holy space, spinal should only have propiocaine or bupivacaine with saline, and the lignocaine comes later on. But when I'm injecting, it will come with lignocaine, needle, saline, and so on in that order. So everyone needs to be wired that way, and that's how simulation can help with this part task. That doesn't stop there. We have to load the right drugs. Sometimes patients are in pain when they have run the epidural infusion because nobody injected the propiocaine into it. And there are technicalities which become randomly seen. Here the needle tap is, the fluid tap is upside down. So there are ways in which you throw case-based discussion with the part task with automaticity enabled in that. Then only you can handle randomness, like how a clip goes off, whether there's contamination, whether somebody can function in a clean level, so there's no infection, injection issues. Now then comes volunteer training. So you have to add technology to learn, and not all the time we can afford people who will be paid for to do this. In this case, this person doesn't look like a pregnant back because it's my own back. We have to do it in so many rounds for people to understand on the model. You dip the model in gel form, that's phantom, and then you can do it on a human being with respiratory movements, anteriorly, laterally, however you want to look at techniques. So people talk about certain courses in obstetric anesthesia for team training, and they all tend to be obstetric focused, like shoulder dystocia. I wouldn't care, but I would be interested if that results in inadequate pain relief and there is an obstruction which will have like cord prolapse or something. So we moved on to simulation, which is relevant to acute care setting where interprofessional contexts are involved. So we associated with a few departments and we brought them together. So if you look at obstetrics, ICU, anesthesia putting together, and we brought in partners from emergency medicine, neurology, when there's a seizure, cardiology, hematology, clots, etc. So that brought in the concept of moving from making the mannequins pregnant and having faculty who are committed to do this and getting the staff between their shifts to come and then move on to settings which can provide maternal collapse where you throw an ultrasound machine on it, you connect to the direct ventilator for ICU shifting, and you have trauma in pregnancy. In India, we have lots of trauma, and some of the mothers are pregnant. And how do we work around that? So that is where when we introduce concepts which are not so comfortable for anesthesiologists, it makes a difference. So we throw in a partogram, and then we talk about what's normal, what's an extended dip, when are you concerned, are they bluffing, is an obstetrician distress or fetal distress, and then how you go about it. So that requires a lot of training. And if you see a star on in purple saying low cost or very low cost, it's how I'm thinking that you could consider in your settings. You don't have a half a crore mannequin, that's fine. You don't need that. But you can just put people around. I can put my phone, I'm operating from the corner there. I give beeps and numbers and it changes, and I have the input of the nurses, emergency physician, obstetrician, and people around here. I put it as query low cost because the costliest input here is the faculty and the time. It's not the mannequin or the setting. So that is difficult. And with Zoom and other things, you could still do online. And the next wave of obstetric anesthetic aspect is conversion to LSCS. When we look at how you can simulate that, if they have a difficulty, so most of the times we have this problem with level of T6 with epidural infusion, and then they straight went to Caesar. No, it's a 0.2% ropivacaine. It's not a surgical anesthesia, and then we have crisis around it. So we simulated that. What about the evidence that what we're doing is actually working? We can show that we are doing this, but is it actually helping? So this triggered during the BJA 100th year publication where we looked at educational outcomes of simulation-based training. This was regional anesthesia. And the template that we were talking about is 50% of simulation need to show at least clinical outcomes, not just simulated outcomes. And what we found is there's need for hybrid simulation modalities where we combine them. We introduce something called level 3S in Kirkpatrick, where you prove they are simulation ready with outcomes, good to go. Then you throw them into clinical effectiveness outcomes. So that differentiation makes a different makes an impact. And look at these settings. And here we have an ultrasound screen on top of the mannequin. And this person is looking at a real-time ultrasound image to get cardiac myopathy. And I love this one on the right side. It's a very engaging scenario. You can call this a dummy. My friend used to say in Tamil, "Bomma vachi vitha kaatittirukkiya." So which is kind of how do you make drama scripts with puppets around it? And we always watch that as a kid. And that's what we have to do in this setting. So the blood on the floor is very difficult to clean. They actually cut out red paper and put it there. So that's how you see low cost settings, easy to tear down and go further. And here, hybrid SP on the low part, she has a different setting which is made, and the upper part she gives the sounds. Some of them cut the table in half and then they stand and then they give the same sound. So you could look at it. And yes, you might see some familiarity to this lady in the blonde hair there. So make your own productions contextual. So you have to get the props to the way you want. No mannequin thrashes around and makes noise and then screams and then shuts off in a way that we could virtually, yes, but we have to have a combination of settings. In these kind of scenarios, we add an image and we just throw point of care ultrasound. We just say, hey, there's a double barrel and there's a low CO2. You're talking amniotic fluid members. Do you want to put an ultrasound probe on it? So there are ways in which we can make it low cost and effective, but there are reasons where we have to move to more virtual and engaging settings. Learners are hiding behind screens, so they love to be on avatar and they interact well rather than being put on spot when it's interprofessional education. And this is something which interested me in the recent conference we went. So the lady is passing a needle under the probe, and then you can see it on the screen, and it's AA-enabled images on there. So that's the probe, and she applies pressure. The needle withdraws into the handle, but it shows like it's going there. So it's time we move to see technology which can be engineered, make in India, and then see how it could be. You can do 3D printing of stuff. Eventually, we are looking from going from unconscious incompetence, conscious knowing that you don't know, to becoming I know that I know, and mastery. So in conclusion, I would say obstetric anesthesia is a simulation based approach is here to reduce critical incidents. We have to look into developing milestones training, specific tasks, algorithms, and full-scale aspects. You go on to develop practice readiness through your mind training, and then you mix them in teams, which means that there is an option for obstetric anesthesia training to individually develop skills, technicalities, the complexities I talked about, and the advanced applied knowledge which you can bring through it from the wealth of experience. Bring in the clinicians, ask them to throw their stories, and then get crisis training. If you can structure what Dr. Tilaka was saying, it's an amazing aspect, especially obstetrics. Why so? Because we need to have a method in the madness, and when things go wrong, there needs to be one person who is looking at where we are going. And simulation is a safe space for the individual, and when repeated, it is preventing adverse events. We need to explore cost-effective ways of improving the learning value and not just throw what they used to call white elephants, the setting and contextuality. Make your own videos, I was talking. So make your message, and wishing you all the best, and I'm happy to take questions, and thank you for this opportunity.
Thank you very much, Dr. Ashoka. It was very interesting lecture where we covered the low-cost simulation to the high-fidelity simulation mannequin. And I was more interested in that lady Ashoka with the blonde hair. It was good. I mean, that tells how much you are, involved there in the simulation, and then you are trying the different modalities. That is very interesting.
I was a third born boy in the house, sir. My mom thought I'll be a girl.
Okay. Okay. So can you ask questions, please? And
Yeah, is there any question?
yeah, Dr. Sankita.
Excellent presentation, Ashoka. Very nice to be with you today. Thank you. Thank you for accommodating your time with us.
There is one question by Dr. Sankita. She asked, so how do you offer the clinical spectrum of variations that clinical practice can show through simulation?
Thank you, sir. I mean, that's an important aspect which we all struggle, and especially when we have faculty being told, can you do simulation? And I used to be told of, I'm talking 15 years ago, and even that now happens, because if you are looking at airway, it does not produce the same movement, it does not have the same saliva, the bleeding and stuff that you are looking at. So what we are basically looking at is having training wheels when they are doing the riding. And once we take off the training wheels, as a parent, or we go along with, to make a slight difference in what all is simulatable, what all is possible with certain aspects like patients who have normal anatomy. Then you layer it with certain adjuncts, like, I was talking about gel phantom. So when they were doing procedures, we attach the gel skin with the ultrasound on the area of the part that we are working on to give and trigger the same responses. So the way of adding absolute clinical variability is deciding what is the variability that we are looking at what level of the learner. So if they have been a junior most person, I was talking about the technique of epidural placement, and then just talking them through, where is your needle, is this in, there's blood coming, this is CSF coming, and then making them do the same with their friends. So peer assisted learning, providing variety of scenarios in their own time. And if I can say, developing cost-effective virtual simulation, which happens at IIT Chennai, there's a collaboration in a big time there. I think Dr. Tilaka would know too. Is one way of giving them content which they can feed through with their mobiles in the commute. There's a lot of time lost in commute when we come to work. And so that is where we could provide that as an option. It is not a replacement for the clinical experience. So any of the clinicians around me are my bosses. There is respect for age and for their experience, and then only anything else can be complemented. Sir. Thank you.
Yeah, as you rightly pointed out, it cannot replace the clinical situation, but if somebody wants to learn the complication, it's not always they need to learn by having the complication on their own. So that is where the simulation comes into the place. There is another question by Dr. Praveen. How do you quantify the level of stress during crisis management in simulation? How do you extrapolate to the real life situation?
Thank you, sir. So I'll just switch the topic there to explain the similar story. We had gold medalists who were having appalling performances in the clinical context, and we were people who are struggling to pass exams. I can sleep for 1 week. I wouldn't even ask about the list, and they are the most efficient. So we figured out that at least for the Indian context, when I was interacting, the selection was exam, it was MCQ based when they went in. It was not by an aptitude of who can be an anesthetist. So when we brought people together and we all have um, people to work in the setting, the aptitude of being an anesthetist is being the captain of the ship. And it's about making the journey safe for the patient. Sometimes you ignore the surgeon, but focus on the patient. Now, when we are the specific question he is talking about is how do we achieve or measure and then achieve optimum moment of stress? There are ways in simulated context. We measure salivary catecholamines, blood heart rate parameters. Now we have Bluetooth connected devices which is giving numbers to you. If we know a pre and post, in baseline, this person is performing like this. In the tea room, in the pantry, this number. In a chilling case, after intubation, with nothing happening, is this number. And then you throw them a simulated setting. So what excites when I am being observed versus what I would actually do are different. And we found certain patterns when people are used to leadership skill. Let's say they were a cricket player, captain. They were in the army leading teams. How they manage is when people call them adrenaline junkies, they are actually calmer when the crisis comes. And that is such a very distinctive profile in anesthetists. So selection of the person matters to who comes to anesthesia. Having come, how do they handle variable levels of stress is the personality. And when known, whether stress is there or not, how do we manage and get operational is a different context. Thank you, sir.
Okay, thank you very much. Do you have more questions? Yeah, I just wanted to ask one. Maybe I think this I can ask both of you. Many times when some resident goes for a training, no, I attended a simulation workshop. There is one more workshop. So already I attended that one. So in that case, like, what is the frequency do you suggest? Like, for example, for the ACLA, they say every 2 years you're going to get certified and trained. So is there any kind of recommendations that how frequently one has to undergo this training?
Thank you, sir. I think there are literature to talk about the number of hours which calls people competent. And then there is other aspect of simulation-based deterioration of skills which happens in 6 months to 9 months. The third aspect is differentiating what is that you are looking at in terms of maintaining. So if I have gone to the Apple store and I have touched the phone and the rep gave me the phone to work on the phone, doesn't mean I'll be able to use it. My teen daughter will come and say, you didn't even know this control, and then she'll click something. I can work. So being present in a setting where there is exposure to a learning immersive environment does not always have the quantum of influence in a clinical setting, because in a simulated setting, you might have 5 people. One is at the hot seat. The observer's learner levels with the excitement which Dr. Praveen was talking about is not optimal. They are not optimally triggered. They don't learn well and they don't retain well. And immersion, whether it works with pre-learning or followed by post-learning, are all things which we can look at. But in general, attending a course only is an exposure to an experience. As a department or an academic setting, we need to map first looking at if it is airway, they can intubate in all conditions, pediatric, adult, obstetric. And then if it is regional, they can do a simple spinal, like a pure perio spinal. My senior resident used to sleep outside. I'll do 12 spinals between 9 to 12. Or obstetric epidural was not given to me till I became a senior resident. So that was how the department or the existing structure can allow volume of practice with a gradation within numbers. And this has to be portfolio. It's a very elaborate process. But unless we have done that, you cannot associate one learning to one aspect. We struggle with that right now because they say, I know him for 2 years and then he will give 3 milligram morphine instead of 0.3 milligram. So I was like, what happened? Oh, that's what it is. Thank you, sir.
Okay, nice. Thank you, sir. I think we have Dr. Sigbinder Bajwa sir is there. Sir, can you please unmute yourself
Yeah.
You also, sir.
Good morning, everyone, especially Dr. Lenin, Dr. Lakshmi, and all the people. Dr. Srinivasan is there. So I think this is a very good webinar right in the morning of a Sunday. You are fresh, you can imbibe so many things, and I'm really impressed with the presentation of Dr. Ashoka because many points he elaborated today, they always come to my mind when I used to say about the simulation because these are the things which are definitely going to stay for a long time in the time to come. And the learning, it never ends. It's always said like that. So going by what the points Dr. Shoka said, I further elaborate that in our country now we have a national program on simulation. And moreover, the uniformity is very difficult to bring. The five fingers are never equal. The most important part of the learning in simulation lab is a leader who is going to conduct that scenario. You cannot infuse the emotions, you cannot infuse the reality, you cannot infuse the right amount of learning for everyone. Everyone's perception is different. Yes, you putting the sensor, the monitor, the blood pressure, heart rate, catecholamines. I think there lies a difference between the learning because in our Indian scenarios, suppose we are heading towards a very vogue type of learning in simulation labs, and when reality we see across the nation where the resources are also limited, that the manpower is not adequate, and you are getting to face same situation in a real lifetime, the panicky reaction, the emotional behavior, the psychological adjustment to those situations becomes entirely different. So whatever you have learned, you may not be able to practice those things. I think in the coming days, what I propose to our national program also, that we should try to provide even the resource limited scenarios also, the manpower limited scenarios also, so that in that particular situation, how we really move forward. Because India is a country where you cannot equate all the systems, all the medical equipment, structures, infrastructures, and tuition together. Simulation is very one good method, and I really appreciate Dr. Shoka the way he explained. I really am impressed by his talk, and I just listened to the talk only for a few minutes, but that was also very impressive. So really thank you, Chisa. I really thank Chisa and Tamil Nadu State for conducting such a good webinar right in the morning of Sunday. Thank you.
Thank you, sir. Thank you for your valuable time, sir. And
Thank you, sir. Thank you for your valuable time, sir. Thank you. Thank you very much.
Thank you, ma'am.
We have another $1 million question, that is Tilaka. How to handle the stress of the obstetrician during the crisis? Kindly enlighten us.
Absolutely, absolutely. I will
Very difficult.
Very difficult to take. So the good point is all of us agree that it is very difficult. So there are two things I think each and every one of us should be aware of. There is one thing called circle of concern, and there is another thing called circle of influence. Like for instance, I am concerned about world peace. I'm concerned about climate change. I'm concerned about how it is going to affect my child. She's just sitting here in the middle, you might see her coming up on screen. So I'm concerned about all these things. But do I have influence on all of these things? So what is the circle of influence that I'm having? The circle of influence is within our limits. What can we do to improve without burning ourselves out? So with a difficult obstetrician or a difficult surgeon or a difficult hierarchical person sitting on top of us, that is a circle of concern for us. But the circle of influence for us is how are we going to keep ourselves calm? How are we going to make sure that the team that is working with us doesn't get stressed out because of this? And because of whatever pressure or hierarchy or stress or unreasonable behavior that the other person is putting, what are the methods that we are going to take to ensure that patient is not getting affected? So that is the circle of influence for us. And of course, if there is a possibility to address the circle of concern, what we should do is how much ever we try and go and tell that this is not going to work, we try to make them sit in a debrief, all of this is not going to work. We need to conduct one major expert, bring some major expert of simulation who has a great name like Dr. Ashoka to come inside the institute and do an in situ simulation exercise. Get the entire team to sit together for a debriefing, and people who are doing that regularly will identify that behavior instantaneously. and will know how to address that. I am not telling that after addressing it, they will change, because behavior of other people is not something that we have control over. We have to try to address it through our own debriefing sessions by ensuring that we call somebody else and give a very neutral perspective. But a more doable thing, a thing that will probably not allow us to burn out, will be to understand, okay, this person is going to behave like this only. This is how they're going to be. Fine. Something that I cannot change. How am I going to respond so that patients are not going to be at stake? And how am I going to keep my team psychologically safe despite having somebody sitting there like that? I think that is a more reasonable approach to take. I am sure that this is extraordinarily difficult to deal with, and all of us have somebody who is troubling us like that. But we should not try to change something that is not under our control, because it will lead to frustration.
Yeah, I think that's very well answered. I think that's a good take-home message that, just then move forward. Just another comment by Dr. Praveen. Do we debrief the event after the crisis management and take it forward from there? I don't see it practically.
So one of the excellent practices that each and every one of us can develop, which is why I think as teachers, each and every one of us should kind of embrace simulation so beautifully, is because it gives us the ability to debrief even after a real life scenario. So when, suppose, say there is an event that has happened in the theater, we're managing that event, we're doing all of those things. After that, for 10 minutes, for 15 minutes, if we can seat the entire team together and learn from that particular event, okay, just in a whiteboard, we write, okay, what went well in this particular event? And what are the things that we want to improve the next time when we are facing with or something which can be, which the learnings from here, can we take this to another event? Just 10 minutes or 15 minutes. It's neither easy nor difficult, but it is doable. It is very doable. After every critical event, sitting and debriefing for marginal gains. So it's called debriefing for marginal gains. Like, for instance, next time a similar event occurs, can we improve our performance, this team's performance, by just 1%? Like that, every single time we are faced with difficulty, if we can just seat the team together and improve 1% every single time, then in a year's time, the cumulative effect of what the team started from as point A to point B will be tremendous. So debriefing after real life incident is a very, very important technique to improvise team's behavior. And once we start doing it, we can never get off it, because it gives us so much, it gives so much value add for the entire team.
Yeah, thank you. Dr. Ashoka, can you comment on this aspect also?
I'll pick on the last bit Dr. Tilaga was saying in a lovely way. When we have an event, we get 2-3 types of teams who work on it. One is why this happened, and the immediate part of things in terms of briefing the family and the teams and the misconceptions and the medical legal aspects in India right now we have. The second most important is the second victim, which is like in my case, I was the one holding on hand pulse, and I said there is no pulse, and then the patient didn't make it. So how do we as a team, without finding the question is not who's responsible or what happened and how can we prevent it from happening? So in a learning way, that you build up the case story for that within the 1 week peripheral debriefing, which Dr. Tilaga was talking about. The third bit is from the lessons learned. It's called zero preventable events. So, hi, good morning. So we do not want a medication given in the wrong place, or some events cannot be repeated. We cannot have a ETT in the airway and then we manage amniotic fluid embolism. So each department which we manage here picks up zero preventable errors, a flavor of the quarter or the year, and then we tell the simulation team, which in this case is me, we sit together and write a program. We run PAKU scenarios or educational scenarios. We also get bored as faculty trying to do the same scenarios like MH. So we just change it and make it flavorful. It is not in the intention of who did this and what happened, and we move from there. And our HR or the legal team also wants us to show initiatives as a learning module. So not everybody can come to this session. Like today's 1 hour, we could record and put it there. And when Dr. Tilaga was showing questions, we pause the presentation and ask on a Zoom poll, what do you think? Option A, B, or C, and D. Here is extra information that you can read. These are the curated articles from my Obstetric Anesthesia SIG group, which says so. And so I was just corrected that we could use cell saver now, and it's part of the international guidelines. I was talking about 8 years ago literature where we don't let the amniotic fluid in circulation. So we, as the team was telling, we constantly learn, and each one has to learn, and we have to face each other. Today this happens, next day this can happen to us. Touch wood, and prevention is better. Thank you.
Yeah, we have another senior faculty is there, Dr. Ekta Roy. Ma'am, can you please unmute yourself and then ask the question?
Hello, good morning. Sorry, I was a bit late to join. I apologize. But my question actually, because I see experts here, so I definitely want to ask. We do conduct, simulations, but then I feel we are very far from the best way of doing it. Because when we conduct simulation, sometimes we have high fidelity mannequins, sometimes we don't. And I feel as a facilitator, we sometimes go and interfere too much with the flow of the scenario. And I feel that's far from the real way of doing it. So I wanted to know, how should facilitator run scenario? And also one more observation, which I thought I should just share because Tilga is there, Dr. Ashok is there. I think in Indian perspective, when we see our students, we are a bit different make from the developed countries. I think if you go to, sugary, we don't really understand too much. I think how we see is when the examiner gets angry, he has to show anger. Otherwise, our delegates will not understand that he is angry. So I think I beg to differ from the Western way of conducting simulation. I think we need to give straightaway points to our delegates so that they can get the point for which they have come. Is my observation maybe wrong? I apologize for that.
Dr. Tilaga?
Yes, sir. I'll go first because you're an expert. We got to take your opinion next. Ma'am, Ekta ma'am, good morning, and thank you so much for bringing about such a relevant thing that each and every Indian simulation instructor is fighting within themselves, because we learn that you're not supposed to talk, you're not supposed to give direct feedback, you're not supposed to discuss technicalities during a debriefing session. But it is not at all possible, how much ever you prepare them technically well, simply because we are not used to this kind of teaching and training at all. Most of the times when we start up simulation, they will be sitting. Why did this happen? They'll be like, what question are you asking? Why? What question are you asking? Why do you think this happened? Why it happened? Patient died. Happened. The ability to reflect is not something that we are taught as children or as medical professionals, and suddenly to expect our students to be brilliantly able to reflect that behavior and bring out some amazing frames of minds and all of those things that we talk in simulation is not happening. After conducting multiple scenarios for multiple levels of people, now I've come to terms with the fact that we need to know the principles of debriefing. Like, we shouldn't completely deviate into a didactic mode. That is the whole idea of debriefing. But what is non-technical skill without sound technical understanding? And in an airway complication, we've planned the scenario to tell them, call for help immediately, re-strategize, have frames of mind, but they are not oxygenating and ventilating. There is no point.
Yes.
So we need to get what the facts are clearly. Yes. And if we have to do that, very mindfully, we deviate. Yes. And do micro teaching in between the debriefing. Being very mindful to not make it into another didactic session where we are only talking and we are not trying to bring out points. But I absolutely agree with you. Without oxygenation and ventilation, they go, okay, I have to share my mental flow. What are you going to share? You have to share this only, no? So that's very, very important. Technicality, if it is not working well, because you see, as much as possible, we try to prepare students well ahead and we bring them. But even then, if we're going to do this, I don't think we need to feel bad about it. I think it's very good to embrace it and say that, hey, I have this set of students and I need to make teaching plans according to the set of students I have. And I want to give these learning objectives back to them when they go home. We cannot have somebody going back without the correct technical knowledge. I also might be wrong in saying so. But I think we need to adapt to certainly to an Indian, not an Indian way of doing it. We have to adapt to the learners, what the learners are and what they want and how we need to do it. I absolutely agree with you, and I do it very intentionally multiple times. I'm going to request Ashoka sir to tell his point of view.
Thank you, Dr. Ekta. Good to see you in face and have read stuff on your writings. Thank you, Dr. Tilaka. I think one aspect is clarifying the intent of the session. If it is to sort a technique, because crisis management should not be confused with drills, which do not necessarily look at certain aspects. So if it is a drill, so that is where we talk about 3-tier approach. Technical debrief. You put the tube in the tube was placed in the airway or tube was placed in the specs. The other part is processes debrief. As a team, you moved from this scenario to this. In terms of outcomes debrief, eventually we looked at how you talk to each other. We looked at how resuscitation has good quality. We looked at how the protocol of ASA guideline was approached and applied in this. So clarifying the intent to the learner like a day before, saying you are having a simulation coming soon. These are pre-reading information. We expect you to have a minimal understanding of this. Give them a pre-training quiz and have to motivate them. You have to give instant gratification and then put that thumbs and the cups. And then on the day of the session, have to follow through with the purpose today is these. I'm happy you all participated this way, but we don't want to go home with us thinking we did well here. This is a psychologically safe environment where it is helping us learn from here. And the second line I was talking about is the Asian Confucianist system or Gurukul, if we can call it, is I think the student and the teacher know that it did not go well. So why hide too long? So let's agree that the circulation did not come back. It's not like, why did you kill the patient? So we just can rephrase it. We can pick up a lot from the Western lingo, but waiting too long in the sandwich model and then hiding is not helping. So we call it the SHIT sandwich. It's not the sandwich model itself. So it's like, let's face it, this outcome was worse. But we're going to put that aside, parking lot, write this down on this board. We will come to that when time comes. But these are our intentions for the session today. And we could follow through. It may not be within that 1 hour because we have to rush back to clinic or something. Can we follow through summary of this? So now we're doing in person. I just put Zoom on the side. I don't have stocks with that, but I just click AI companion. It summarizes the meeting with who said, and then I just attach that to them saying this was discussed, and then you have anything to follow through. You can try that option. Thank you.
Thank you very much. I think we'll take one final comment by Dr. Geeta Nath. She is a senior faculty member. Dr. Geeta, can you please ask the question, ma'am? Dr. Geeta Nath, can you please unmute yourself, ma'am?
Geeta, ma'am.
I think I'll read the question. Her comment is, it is important to have a clear learning objective for each session. The facilitator should not interfere during the scenario, but during the debriefing, they should be flexible. See the discussion to bring out the learning objective, but do the micro teaching when required. I think maybe having some issues with the computer.
Hello.
Yes, ma'am.
Sorry. Yeah, I was just saying that, I was listening to the discussion and reading the chat as well. I just put a message, maybe it will help answer Ekta's concern that before each session, we have to have clear learning objectives. and we try to get them out at the end of debriefing. And the facilitator's role during the scenario, let the scenario proceed, don't interfere. But during debriefing, we need to steer the discussion to bring out the learning objectives. And if necessary, do micro teaching then, because we don't want them to go back with misconceptions or wrong ideas of how to manage.
Thank you very much, ma'am, for your comment.
Yeah.
And I think there are a lot of questions there in others' mind also. Maybe I will request everybody to register for the workshop and then be present there to take the actual learnings and then do it.
Yeah.
And,
thank you, sir.
Thank you very much.
It was an excellent session, and thank you, Dr. Ashoka and Dr. Tilaka, madam. Now I request Dr. Can we proceed for vote of thanks, sir?
Yes, thank you very much, ma'am, Dr. Subbalakshmi, for inviting me to be a part of this wonderful.
Yeah. Thank you, Lenin sir, for covering up in between. I had been called and I was. Thank you so much.
Thank you very much, ma'am.
Thank you. Thank you.
Thank you, Subbalakshmi, madam.
Thank you, madam. Thank you, madam. Thank you, sir. Thank you, everyone.
Thank you.
Dr. Subbalakshmi, madam.
Thank you, sir. Thank
Vote
you.
of thanks. Vote of thanks. You can proceed.
Okay, sir. Now I request Dr. Santosh to say vote of thanks, sir.
On behalf of ISC Chidambaram, we thank our esteemed speakers, Dr. Tilaka ma'am and Dr. Ashoka sir, for casting a spell of knowledge in the field of simulation. Hope it inspires a lot of young minds to take up training in simulation. We thank our ISC National President, Dr. Balavenkata Subramaniam sir, our Honorary Secretary, Dr. Sukhwinder Singh Bajwa sir, our GC Coordinator, Dr. Hina ma'am, for gracing the occasion. We wholeheartedly thank our eminent chairpersons, Professor Dr. Amudarani ma'am and Professor Delin sir, for presiding over the webinar. We thank our state dignitaries, our ISC Tamil Nadu President, Dr. Kribakaran sir, our ISC Tamil Nadu Honorary Secretary, Dr. Srinivasan sir, our academic chairman, Dr. Selvakumar sir, our ISC Tamil Nadu President-elect, Dr. Rajkumar sir, our ISC Tamil Nadu academic chairman, Dr. Selvakumar sir, for gracing this occasion. We thank our senior professors, Dr. Ekta Rai ma'am, Dr. Meenakshi Sundaram sir, Dr. Veeresham sir, Dr. Geeta ma'am, Dr. Dakshinamurthy sir, and other senior faculties, and our colleagues and below postgraduates for attending this webinar. We are eagerly awaiting to meet all of you at CISA 25 on the 9th of March, September. Thank you all.